For those of you that are thinking of upping your game and transitioning into a higher level of shelter medicine, we have a couple of caveats. If you are folks that are associated with a shelter or rescue that has really high intake and or you're open admission, then you're going to have to consider a couple of things as you're adjusting what you're planning to take on in your medical program. So one thing that we find on a daily basis is that we are not in control of the number of animals that come in. And as a result, some days we do just fine, and other days we have to make some hard decisions. So make sure that you are not biting off too much more than you can chew. And trust me, we learned the hard way. So also you're going to have to ask yourselves realistically, what kind of resources do you have and what things can you afford to treat and have the staffing to treat? So what we started with 6 years ago is nothing like what we have today with regard to the number of vets and the number of technicians that are dedicated to our medical program. I know Austin has probably gone through a similar progression. So we're going to talk you through how to start slow and work up to being something that's 90 plus in what you can save and treat at your facility. The other critical piece is, as you're starting to save more, please be aware that as your population census grows, you are much more likely to develop infectious disease or have outbreaks that you formerly didn't even think were in your population. So please be cognizant of that. And we're going to start with a couple of cautionary slides, and then we'll launch into where you can go from here.
Okay, so intake, super important. You're going to be doing this every day, all day for the most part. And so you want to have a good protocol that everybody follows exactly the same every time. So these two are examples for cat and dogs. Cats are going to get their FERCP vaccine. That's mainly to prevent Pan-Luc as well as calicivirus. That starts at 4 weeks old and up. They're going to get it every 2 weeks until they're 5 months if they're in the shelter because it's a higher risk population. And then rabies, you're going to want to give them if they're older than 3 months. So you're going to want to make sure you know for sure they're 3 months and older because it's actually illegal to do it sooner and it's not going to work. And then Strongit is your broad spectrum dewormer that you want to give everybody. Flea prevention. The key here is for cats, you can break up the bigger packs for like big dogs, and for instance, Frontline Plus can be used on cats. You want to make sure that it doesn't have anything toxic to cats, so you want to ask your vet first to make sure, because they can have a bad reaction to some of the ingredients. And then FeLV testing, which right now, you know, with all the research, that may be something that your shelter doesn't do for cost efficiency. If you're not going to do anything differently with these cats. So that's up to your shelter and how much you can afford. At APA, we don't do FIV testing anymore, and that's pretty much across the board. We're not doing anything differently with these FIV cats. So, and then microchipping everybody, that's super important to know if they get loose, if they get adopted and then found, they can be returned to an adopter. And then dogs, some similarities, but the main thing with dogs is you want to get that DHPP vaccine in as soon as possible. That's going to help prevent parvo and distemper. So immediately, if you could do it before they get on site, I know that's usually not possible, but if you can do that or get it in them and send them to a foster before they come on site, you know, that's the best. But anyway, get it in as soon as possible. Bordetella to help prevent kennel cough, rabies again if they're 3 months and older, Strongit flea prevention. And then heartworm prevention, the key here, you can give ivermectin orally as long as you're giving the correct dose. It's when you get the ivermectin injectable, it's 0.03 mil per 10 pounds, so it's a teeny amount. So it's very cost effective. And then the microchip.
So one thing that we see routinely at our shelter, which is open admission, is that there are a lot of cohorts of animals, and even though we are going toward individualized treatment to save the last 10%, please be aware always and make sure that your staff and your Animal Protection Service officers are aware that there are populations within your population, and the best time to manage those is when they're coming in. So litter mates should all be treated as if they have the same diseases. A hoarding house is probably infested with the same numbers of parasites and types of parasites. Backyard buddies, if one of them has distemper, you better be worried that all of them may be shedding or carrying. Free-roaming dog packs, that's where both of our strep zoo outbreaks have come from, so please keep in mind that if they're free-roaming together, they're sharing cooties. Cat colonies, everyone can kind of think through the logic on that, right? And then animals that are unlucky enough to be on trucks or transport with animals that are shedding distemper, parvo, panleuk, strep zoo, all of those need to be considered carefully for their exposure and managed appropriately. So even though we can save distemper, parvo, strep zoo, panleuk, etc., we want to know who else is exposed because that's really important in keeping that from raging through the rest of your population. And you can go ahead and forward it. Recently, I don't know what's going on in Arizona, but we've had tons of bed bugs in our hoarding houses. So beware if you haven't seen it yet. So once you've got your basics covered, you're managing your population very carefully, then you can start thinking about doing the individualized care. And I must say, once we got to that point, and it took a while, we learned some hard lessons, we realized how fulfilling it was for our staff to take on these animals and how much positive feedback and money we got from our community, both in donations directly to our shelter and to our nonprofit. So do your homework first, and then you're ready to launch. In Tucson, this is Decoupled. It used to be that we struggled all the time with containing respiratory disease, and we have tons of distemper, strep zoo, lots of things pouring in every day. As we moved into our new shelter, managed our population more carefully, got our vaccine on intake protocols down, we were actually able to see a pretty good drop in what we were taking in terms of upper respiratory infections in dogs. And what you see in the spikes of the dashed lines are hoarding cases where 30 Khaleesi cats come in at once. But what we're now managing with most of our time is a really large number of fixer-upper cases, animals that come in with significant trauma, the old farts, the dental disease, and allergy animals. And we spend a lot of time on those, and we're now more of a recycling center than a pound. So if you're going to start and ask yourselves, where do we want to go towards that no-kill benchmark? Again, first make sure that you've got your basics under control. You should have protocols that are very easy to follow for upper respiratory disease, diarrhea, wounds, mange, and allergies. Those are things that most people can ease into. Most veterinarians will feel comfortable doing that. What's obscured behind that, and unfortunately the animations are not working for some reason, is that cute little poodle with a splint on. Underneath that is be careful of not knowing if you have distemper in your upper respiratory complex. Hopefully you guys can manage that and work towards that, but if you've not managed distemper in your population before, don't make that the first thing you try to start saving, especially without good support from shelters that know how to treat and get away from it. The second tier of things that we started to add, and Dr. B can jump in, at PAC, we started with one shelter vet and two medical technicians, so we eased into things. And what we considered our second tier were things that we had to add once we had a place to actually isolate things. So ringworm came along only a year and a half after I got there. We were euthanizing ringworm before that. We were euthanizing Khaleesi. We were euthanizing a lot of things. But once we got going and got some isolation, we started treating ringworm, seizures, basic dentals. Another picture, yeah, we have lots and lots of animals that come in with skin tumors. They're so unsightly, nobody wants them, but it takes moments to lop them off. So we started tackling that. TVT is pretty easy, and we have tons of it. So we started doing TVT on the animals from our tribal nations. Parvo, we finally got there, and hyperthyroid cats. That's pretty easy stuff. And our first parvo isolation space was an unused euthanasia cooler. So make sure that you've got your things in order. You've got to isolate if you're going to start treating some of this. Going forward from there, in the next year or two, we started adding really intensive dental procedures, so total mouth extractions, full mouth extractions for cats. This, again, is like one of the chronic things we see in so many hoarding cases. We're now doing heart failure and heartworm. All of my vets know how to do FHOs and medial patellar luxation fixations. We do feeding tubes and yellow cats, and we're trying to treat some chronic renal disease. And then the last things that we're really easing into, and then this is something you've got to really have You've got to have your staff trained up carefully to help you manage this. Blocked cats, urinary catheters. Dr. B taught me how to do perineal urethrostomies last year, so now we're rolling on that. We're treating diabetes, we're treating lymphoma, and lots of other hospice conditions. We're learning to plate bone fractures, and we're easing into treating FIP. So again, 6 years ago, we weren't even treating calicivirus or ringworm. It's been a progression, and we've learned some hard lessons. Oh, that's a lymphoma cat. She's doing great. So how many vets do you need to manage all of these tiers of things that you can and hopefully will eventually get to treat? Well, instead of asking that, you might start with how many vets do you need to actually get good diagnoses? And you should really focus on getting that with a quality physical exam. You need to make sure that you're mentoring your younger veterinarians carefully. And once you get your diagnosis, you should be educating your staff on how they're going to take care of the animals for you, because this is not something that a veterinarian can manage on their own. You can go to the next one.
If I can just make a note on that, the physical exam is super important, and that's what I've learned over the past 6 or 7 years I've been doing this. There are things you can pick out, or a veterinarian can pick out on the physical exam that may not correlate with the blood work. You know, if you can find something on physical exam, it's going to tell you a lot, where blood work and RADs may not tell you a lot. So if you have vets, really try to get vets with good physical exam. You know, they're really good at what they do, and when they're doing physical exams, and they can pick out stuff, and they don't want to rely too much on the diagnostics.
So of that subset, the conditions in white are things that your staff, fosters, and volunteers can be managing for you once you get them appropriately trained. So again, you're taking on a lot, but after you get your plan in place, hand it off to your skilled staff.
Okay, so triaging is going to be the main thing here, and especially when you're talking about the veterinarian, they're going to be multitasking, so you want somebody that is not going to spend a lot of time on one case. You know, we're talking about maybe 5 minutes. They're going to do their quick physical exam. When I say physical exam, I'm not talking about A to Z. They look at the entire animal. They do the absolute necessary things, like look in their mouth, palpate their abdomen, listen to heart and lungs real quick. So it's not extremely thorough, but it's an exam that you know where to pinpoint what the major disease process is and where they'll be. And then you want to be flexible on your drug choice. I mean, that's a major thing you want, and we'll go into this about looking at different options, generic meds, you know, versus brand name meds, all that. Following protocols for efficiency, we talked about that at our presentation yesterday, because you want everybody to do the same thing all the time and get really good at it so they're quick when you're talking about your team. And then only spending more time and money on the conditions that are going to have more potential to be lifelong issues or have lifelong pain and that sort of thing. Okay. So again, you want your staff and volunteers to be well-trained, good protocols, train them well so that they're very efficient. Intake is super important to have the same protocol all the time. You know, you want protocols of your most common diseases and teaching basic physical exams. More staff does not necessarily mean more work gets done. If you have a less efficient staff, you know, 4 staff members might not do the work of 3 that are more efficient. So that's where the training is key. And you don't always know when you're hiring somebody, but you want somebody that's proactive, that's going to jump in and be like, how can I help? How do you do that? How can I learn more? Versus somebody who just kind of sits there and you have to teach them everything and kind of push them along, because those people that are proactive and passionate are going to be the ones that do the most and want to strive to do the best job and save as many animals as they can. And you want to teach your staff to teach volunteers. Not everybody likes teaching, and it does sometimes take more time on, you know, the forefront, but in the end, the volunteer help decreases your costs dramatically. So there's an inverse proportion to cost and then life saving. So, you know, as the cost decreases, your life saving potential goes up. So, you know, there are some keys to saving money, having protocols again for the efficiency of your staff and volunteers, lower cost medications for antibiotics, you know, antibiotics, pain medications, You want to calculate the risk of death, so if a neonate's going to go downhill really quick, you might bump them up to a more costly medication. And then not choosing the gold standard. We hardly ever do the gold standard at APA. I mean, there's always going to be like either a middle line procedure, or something that's super less costly that with time the animal will recover. So going over some medications, I'm going to go over the right column here first on how we're choosing them. And so antibiotics, we're going to try to choose the generic as well as pain medications when possible. So you're talking about like amoxiclav versus Clavamox. Our APA, we kind of have a general rule, we do not use Clavamox. There are very rare instances, and it's basically like we log it out. I mean, it's very, so if you use it too much, you get reprimanded, just because it's so expensive. And then we don't do diagnostics on infections until we've at least tried to treat them. And then if that's not working, then we'll do a diagnostic. So for example, of chronic wound, skin infection, we'll start our first line broad spectrum antibiotic, and if it's worsening, not doing well, after a month or so, it's this chronic infection, then we'll pursue culture and see, what kind of bacteria are we dealing with? Do we have to do something, bring one of the big guns out, and that kind of thing. Pain medication, use the cheaper oral alternatives when you can. There's injectables like Bupesar that last for 3 days. There's fentanyl patches and that kind of thing, but those things are a little more expensive, so you want to try to use the oral alternatives. Times you do use those more expensive, longer lasting ones would be for severe pain, maybe like an orthopedic procedure, oral pain if your vet did like a full mouth extraction. You don't want to be messing with their mouth a lot right after, or if they're fractious, or if you have maybe a feral cat that has an injury and you want to, just give it one injection that'll last. And then fentanyl, that's something that you have to talk to your vet about because that's a very controlled substance, and so probably only if you have a vet on staff that's really monitoring that is when you'll actually get that medication. It's very good for pain, but it's abused, unfortunately. And then sedatives, you also want to look at your sedatives for spay neuter and just anesthesia in general because, there are lots that are really expensive, and if you could use something else, why not save the cost there? So ketamine, acepromazine, those are really cheap. For us, that's what we use for our dog spay neuters. Diazepam, is more expensive, and then dexmedetomidine is expensive, so we still use those, but just don't use them as much or just in certain situations, depending again on your funding. I don't know what you guys use.
We try to economize, but we do use a lot of Dexdome in the interest of time.
Yeah. So the most commonly used medications, at least at APA, are going to be those antibiotics, Doxy, Cephalexin, Amoxy, Azith, clindamycin, and we'll touch a little more later on about where we use these, Baytril, Polyflex, and then your diarrhea medications, metronidazole, praziquantel, Marquis, Panacur, and then Pen-G. Sub-Q fluids is a great thing that I think anybody should be able to do. It's great for dehydrated cats, even dogs. It's easy, you can get the equipment pretty easily. If you have IV catheters, and you can get an IV catheter in, you can do IV fluids and keep either LRS or sodium chloride or both on hand. And then the most frequent pain medications are Metacam, Carprofen, buprenorphine, gabapentin, and tramadol. At APA, we're using a lot more gabapentin, and mainly because tramadol is controlled now, and gabapentin has less renal effects or kidney effects. Metacam, if you have a cat on Metacam for too long or at a high dose, it can affect their kidneys, so you got to be real careful with that. But gabapentin is really good. So what you don't want to skimp on are pain medications. If an animal's in pain, that's one thing we want to control because that's a quality of life issue. And And then really being proactive on certain types of disease processes like the eyes, because we want to try to save them, and they can go downhill quickly. So, you have an eye issue, you start treatment immediately. Neonatal illness, puppies and kittens, especially when they're under 6 weeks old or under 1.5 pounds, they can crash really fast. So we want to initiate treatment and sub-Q fluids, make sure they're hydrated because they can get dehydrated and hypoglycemic super fast and die. And then punctures are something that somebody looks at and they're like, oh, it's a tiny little wound, it doesn't need anything, but that means that there could be a big pocket underneath with bacteria, and then that tiny wound closes over, and then you have a huge abscess. So punctures, you want to treat even though it doesn't look like it's that bad of an injury. So ways you can really help save money on all this is accept donations if it's legal in your state. We have tons of donations, and a lot of really expensive medications are donated, and so we could use those. Otherwise, we would never even buy them for the most part, unless it was sponsored by a foster or something. Breaking up medications, like I said before, the Frontline, you can dose out of the big, aliquots for the bigger dogs, and then iMeds. You don't want to give a whole tube of like erythromycin to one animal because a lot of it's going to get wasted. So we break it up, and it's kind of a pain to administer, but it goes much longer of a way if you just put it in like a 1 cc syringe and give that out. So you can share that tube amongst multiple animals. Revolution's the same as Frontline. You just have to make sure the dosing is correct. So you want to make sure with your vet that you're doing the appropriate dosing. For mange and whatnot, Bravecto, you can, score the tablet if needed. And then, asking for donations, that's just key for any supplies and whatnot. So some reasons that animals are euthanized at no-kill shelters, and it's justifiable. No-kill does not mean that we're totally against killing any animal. It means that if they have the possibility of having a quality of life, that we're going to keep them alive and try. So the few exceptions are going to be animals that come in, maybe they were traumatized, like the first two here, or they come in with a chronic illness and they've been going downhill for a while. And unfortunately, we get them, we try to initiate treatment, but they're just too far gone and they continue to go downhill, and nothing's happening with our efforts. Those would be ones we say, okay, we can't help them, we're going to euthanize them. Chronic conditions that, they're going to be painful for life. That's going to be another thing. So if they have some crazy, gnarly spinal fracture or multiple spinal fractures and a really bad place to where they're never going to walk again, but they're also always going to be painful, that would be something that we would euthanize. And then aggressive dogs, that are rehab, that have gone through a training rehabilitation program with a behaviorist, but they're still, aggressive and dangerous. So these are some examples of the most common cases we see that usually, non-shelter vets are going to look at and really be stressed about and say, oh, can I really save this? Is there a chance? Or they miss little things. So head trauma is a huge one. We see a lot of cats that are hit by cars, their eyes popping out, their head is swollen. Sometimes you can't see either eye, their jaw is fractured. They may have blood coming out of their mouth and nose, but they're semi-alert, they're systemically still, somewhat okay. We get them in, we're going to stabilize them, we're going to get an IV catheter in them. The most important thing here would be we're going to give them hypertonic saline, which is going to help decrease the pressure in their brain, because with head trauma, they start to swell, and that's what causes a lot of the other symptoms. We're going to do that. We're going to then get them on like regular fluids to help hydrate them and keep their circulation going well, warmth if needed. And then force feeding comes with time. If their jaw's super messed up and they're super out of it and not swallowing, you're not going to force feed them, but you're just going to give them some time. Get them on pain meds, obviously. That's a huge one. make sure they're pain-free, and just start to stabilize them and give them time. And it's amazing with these cats. They look like they're pretty much dead coming in, and then within 24 to 48 hours, swelling starts to go down. They might lick food. They're like looking at you, and they're on pain meds. Sometimes they're like overly happy, like, and it's not the sick purr. It's like you can't even believe they were just hit by a car. They're lovey and all, and it's really amazing. But so once they're alert, and looking around, and their gums are pink again, and then you can try to start force feeding them, maybe put a feeding tube in if they're stable enough to anesthetize. But mainly the initial stabilization, time, pain meds, maybe antibiotics if they have wounds, and those guys do great overall. And then the next group of animals are the neurological animals. And so these, you can't, it's kind of a broad topic, and you kind of need a vet to let you know that, yes, this is a neurologically abnormal animal, but they're going to be wobbly, they're going to be circling, just not acting as bright maybe. A lot of these guys will slowly start using the use of their limbs. So you might have a dog that he's walking one day, and then he doesn't use one of the limbs the next day, and then the next day there's total loss of both hind limbs, and it just kind of progressively goes downhill. Any neurological case we have, kittens, cats, dogs, we put on clindamycin, and we've learned the hard way with a dog that went downhill, and for some reason it got past all the vets, and nobody put it on clindamycin. And then we had the neurologist come and do a consult, and the first thing he said was, have you tried clindamycin? And we did not. And within 48 hours on clindamycin, the dog was walking again. So clindamycin, and it's not expensive. It's just an oral medication, and so that'll just be the way you can rule out toxoplasmosis or neospora, which are parasites that attack the cerebrospinal fluid and cause the neurological abnormalities. So, not saying that they're all going to respond, but if you have an animal that's neurologically abnormal, I would always have them on that. And then in addition, if you're not sure, you haven't taken RADs, so you don't know, maybe it is really a spinal issue, a slip disc or something like that, you want to get them on pain meds. Again, gabapentin is a really good pain med. And consult with your vet about if they want to do a non-steroidal anti-inflammatory or a steroid, because you can't use them together. You have to use either or. So, and they'd be better to determine that. Then the next class would be fractures, and we see a ton of those. You're definitely, the key here is that when you get an animal in that you suspect a fracture, they don't want to get up, they're super painful. A lot of people immediately freak out and say, oh my gosh, what are we going to do? Well, get them on pain meds, let them rest, get them in a nice padded kennel, treat any wounds with antibiotics, and then proceed from there to, do what you're going to do. Are you going to, go find another rescue to take the dog, or, try to raise funds to get a radiograph to see what's going on, or if you have a vet, have them do an exam. Most likely your vet's going to find what's wrong for the most part. If it's an obvious fracture, they could feel that. But these guys, sometimes they don't even need a lot of treatment. If it's a femur fracture, we actually don't splint femurs. So if it's a femur fracture and everything's somewhat lined up and the bones are in close proximity, with time and pain meds, that should heal in 6 to 8 weeks. Gold standard is going to be doing orthopedic stabilization on it, but not everybody can do that. And fractures heal really well with time, especially cats. Cats are amazing. They heal. I've seen crazy fractures, and cats heal with time. But when, if you have, there are times you're going to want to surgically fix these, or raise funds to surgically fix them, or send them out to get better treatment. If there's a fracture at a joint, that's never going to heal correctly, so they're always going to have really bad arthritis or non-usage of that limb because the joint doesn't work properly. If it's severely displaced where the bone ends are totally separate and not in close proximity, or if it's a very, very open or like shattered fracture. And then times to actually amputate are going to be when you have an open fracture that's really infected, that's really old, that's not healing, it's past the point of really saving at that point. That would be when, you're going to want to amputate.
Excuse me. So with severe trauma, we unfortunately have a really high caseload of trauma at our shelter. And at this point in time, we don't have overnight technicians. So even though we know that a lot of animals will heal really well with just the right amount of time, you're going to get to a point pretty quickly if you're trying to save them and asking yourselves, are you doing the right thing for the animal? So in the case of this dog, she was attacked by another dog and had a collapsed chest, multiple broken ribs, and a crushed pelvis. But she was otherwise young and in good body condition. However, she couldn't be left overnight on her own without fluid support and multiple more injections of antibiotics and pain medications. So she ended up in my bathroom overnight, which happened a lot in the olden days. Starting tomorrow night, our administration has recognized that this is a major problem for us trying to save these animals. And so we have 2 overnight technicians starting tomorrow night. But when we didn't, we had to make some really hard decisions about what's humane and what's not for animals that might survive if you give them enough supportive care over a couple of days. So this dog pulled through just great, and there's one more photo on this. And unfortunately, she lived too long at my house and now is a permanent resident in my son's bedroom. There's a picture of her. Her name's Chuchita, which means little troublemaker. She's rotten. So you can go ahead to the next one. So beware the overnight care.
Some chronic issues we'll talk about here, like this dog. This eyeball has been out for, maybe a week or two. It's so a pretty long time. And so it's not an active where it just happened and they're feeling the acute pain and all that. So these guys, you're obviously going to want to get that addressed and get the eyeball taken out, but it's not something that within like the next 24 hours we got to get it to the e-clinic and, or to the vet and get it taken out, because it's not going to be as painful as when it initially happened. So these guys, even at APA sometimes, we're bombarded with so many cases, our surgery's backed up. This one is just going to go on the schedule and we're going to get it on pain meds, maybe an antibiotic if there's some nastiness around there, get it into a foster home, and then, eventually remove the eye. So in the meantime, you're raising funds for it, and yeah, that'll be okay. Some other chronic cases, geriatric animals, we see them all the time. Big dogs especially, you have that big fat lab that walks in and, doesn't walk in because it can't walk. And it has major arthritis. I mean, you could just feel the crunchiness in its limbs, but it's not on anything. So these guys, when you get them on pain medications, carprofen, joint supplements, fish oils, you'll see like within 24 to 48 hours, they'll be walking around, you're gonna lose some weight, they might have a few more years ahead of them. And so those are the pain meds we'll typically use. Again, we've gone to using gabapentin a lot. But for the really severe cases, you might have to do a combination. And joint supplements really are good. So, if you could do joint supplements, get these dogs on those. Cats as well, I don't want to leave cats out of here. Cats do great on GABA. We'll also do sometimes Adequan. We get a lot of Adequan donated. It's like a horse injectable, and it's really good for the joints, and it's a very easy subcutaneous shot that a foster or can do easily, and that works really well for cats too. Diabetic dogs and cats, these are the hard ones because you really want them in a foster because it's so easy to mess up on their dosing regimen of insulin and feeding. So they really need to go to a foster. If they stay within the shelter, you need a pinpoint person, whether it's your clinic and a clinic technician or like one specific person or 2 people that do this because it can get messed up really quickly, but they are super savable. And I mean, we have so many diabetic cats we adopt out. And cats, you can sometimes stabilize on food, which is the good thing. So if you get them on the right diet, sometimes they'll regress and, you know, you don't have to actually give them insulin. Cats with renal failure, you know, those come in, kidney failure a lot. They're just your older, dehydrated cats. If they're in good body condition and they're eating, you know, there's no reason not to take them and try to get them into a home. Like I said, if they're eating, doing well, we'll adopt them out as long as the adopter knows what's going on and what they'll need for the future, and that their life expectancy, you know, is, we don't know, it's shorter. But these guys, you also want to get into a foster home if you can, if they're not adoptable per se. So if you get one that's losing weight, but it's still eating, but it's kind of thin, you know they're on the decline. Those guys we'd want to get into a foster home. And I don't know if you guys have the quality of life scale, but there is, and you could look it up online. There's a few of them out there, but it's a very quantitative measurement of knowing when the quality of life, you know, is not good to where it's time to call it, because, you know, that's hard. That's a hard topic you want to put, especially on a foster. I mean, on anybody. So that quality of life scale really helps, and you basically, you know, give a rating to each factor. You know, are they eating? Do they like attention? Are they continent? You know, are they moving around or just hiding? It's just things like that.
And one thing I'll add about diabetics is we've just started treating them in the past 9 months. And our community is not very amenable to adoption. So we have a growing number of diabetic dogs and cats that came in as euthanasia requests, and we managed to turn them around. And our foster base is really going toward taking them without letting them languish in the shelter for a long time, but it took a lag for that. And now there's another lag in whether or not the community is interested in adopting. So beware with any one of these like more chronic issues that you're starting. It may take some time for your community to get over their initial bias toward how hard is it to treat a diabetic, how hard is it to treat a ringworm kitten. And with time, you could probably get there, but just be prepared to make sure that you are expanding your foster base with each one of these chronic conditions that you're hoping to manage.
And then there's the hospice group of animals. And this was kind of the last group that we focused on at APA, or one of the last. And they're tough, you know, because they do have a terminal issue. We try not to use the word like terminal disease at APA because we found a lot of them tend to live longer than we think initially. So we've had heart failure dogs that I personally gave it maybe a week or two. We got it on treatment and it lived 3 years and got adopted. So, you know, but when it is a hospice, you know, if your vet finds a mass in the lungs, this little girl, she has a very large rectal mass, and so it's just too invasive that we can't remove it. And so that deems her hospice. So basically, she's going to be treated until her quality of life is no longer there, with pain meds and, you know, just love in a foster home. But basically, these are the animals that they're not going to get better, and we know that. We know there's nothing we can do for them. Focusing is just on control of pain. They may get an antibiotic if it's some like nasty oozing wound or mass and that kind of thing. But we know that they only have a short time to live, and we disclose this to the foster and make sure they know right off the bat that this is the deal, you know, so they're aware and there are no surprises there. We also, a lot of these we keep up for adoption because, like I said, with that heart failure patient, you know, he was able to get adopted, and so some of them can be adopted.
So as we've started starting with trauma and going forward with the more intensive internal med cases, again, we get so much trauma that a fractured femur is no big deal. We see about 2 broken bones intake per day in the summer months. So this particular dog was, you know, we don't know how she fell off the bridge, but with a femur fracture that comminuted, there's probably no hope. So we went ahead and amputated, and that was great. She recovered beautifully. And then she went out into foster care for for recovery and then got bit by a rattlesnake. And then subsequently, we found out that she was heartworm positive because in Arizona, we don't test everything, especially in the southern areas, because we don't have the mosquito burden that a lot of you guys have to endure. So as you're ramping up your program, you might find when I started, any one of these would have been a reason to euthanize. But as we've gotten people more adjusted to treatments, particularly our foster care base no longer freaks out about a heartworm treatment. We have no problem getting them into foster care, that we've been able to expand what we can do, especially if it's an animal to whom we're all really, really attached. So you can go on to the next slide. And then, as Dr. B was saying, there are some cases for whom you should really refer. And we often learn the hard way about what the limitations of our own skill sets are. So the dog on the left came in, she was an adoption with severe separation anxiety. The adopter didn't dig it at all, threw her in the backyard. She launched over the wall, as a 70-pound hound dog should, right? And came in with the mid-diaphyseal tibial fracture, and the leg on the left, you can't see, but every one of the ligaments is destroyed in that other knee. So what we hoped to do was have somebody slap on a bone plate real quick on the tibia, because that looks like a no big deal kind of fix, and then refer for the more intensive fixation of that knee that's in front. Well, we sent to a relatively low-cost clinic, and what we got back was the infection and dehiscence with 3 or 5 days after that surgery. And the next slide will show you, this dog ended up costing us another $8,000 to save, because the infection from the easy leg was bloodborne and moved into the knee on the other side. So both of the repairs ultimately failed, and after 11 months, she can almost walk on both of her legs. But it was a really hard lesson that sometimes you should refer early and perhaps to a specialist that knows what they're really doing. And APA is very lucky to have specialists that will pop in for them, but we pay out the nose, and so we are really careful about how much money we spend, and we know now sometimes we need to spend it wisely, more wisely. And then the last thing we're going to touch on is something that we're just, both APA and PAC are just barely wading into, and this is the disease feline infectious peritonitis that has for us been an instant euthanasia once the firm diagnosis is made. And with the advent of the oral antiviral synthetic nucleoside treatment, it was developed initially for human coronavirus, SARS, Ebola, but as it wasn't as financially successful as they'd hoped, they offered it as a potential treatment for FIP. And the word is out that it actually works pretty damn well. It's a nutraceutical, doesn't require a prescription to buy, so my first cases that were being treated in our shelter animals were purchased and or loaned by people that already had the drug in their care. So we're trying to work backwards to figure out how we can manage this a little bit more carefully. But in the 2 cases that we've managed, it's been a really alarmingly effective treatment. So Newton, 3-pound kitten, dry form, really severe uveitis. You can see his pupils are really distorted, severe jaundice. He was in hospice care. We didn't think he would make it. And the foster heard about the treatment, managed to get some from a local support group, which was not at all in the shelter or rescue community, and paid for it out of pocket. And after 2 weeks, the jaundice had completely resolved and the eyes had normalized. So the cost for this drug, for this particular kitten's treatment, is going to be $3,300 for 3 months. And we do not know if it will recur, but at this point, we've seen tremendous success. So the next case, you can go on to one more. Oh, and by the way, I asked, and they don't offer any shelter or rescue discounts. And as Dr. Levy mentioned yesterday, you can get some formulation of this from China and from other markets, but you may end up spending a significant amount of money for something that is completely ineffective. We went the high-end route and we saw tremendous results. The next case, and I don't have a picture of this freaking adorable Persian, but she's 5 years old, she had the wet form. The previous bull is a couple hundred mils of effusion that we had been systemically tapping off of the abdomen. Again, she was in hospice. Same foster spent another $1,000 out of her pocket, bought the Mudian, and over the course of a week, the effusion resolved, and the cat's doing amazingly well. So at this point, we reached out, and go ahead, our deputy director and the foster went and did a GoFundMe. They got the majority of these costs covered, and then our nonprofit partner kicked in the rest. This is the first time we're trying to treat this disease, but it's just an example of how, as medicine marches forward, there may be more and more things that a year ago I would have laughed if somebody said we'd be treating FIP, and yet here we are. So with that, I would encourage you all to be really open-minded, but also like mind your dollars, because they can only go so far.
And I just want to add one thing here, that work with your vets and communicate with them and ask them before you just try this, because it's kind of a controversial topic right now, and it's not, super legal on the vet side of things, and so a lot of vets are afraid to use it, and they don't know what's going to happen because no one really knows exactly what's going on. So it's better to communicate with them and say, hey, I heard about this and I was thinking about using it. What do you think? And just open that up before you just kind of do it. And then you bring them a cat and you say, oh, we're doing this, and it's a surprise. It'll just make everything go more smoothly.
Definitely, and there is no guarantee after 3 months that the virus won't recur. So these are our baby steps into treating this, but something that we should always be looking for is the new saving treatment. So with that, okay.